This is our first podcast talking about the outputs of the 4 weeks of co-design work that we did across March and April. So I'm John Edwards, I'm Associate Director for Transformation, leading up the transformation work.
And I'm Rod Melling, so I was helping to facilitate on the 4-week co-design workshops.
So across March and April we had 4 weeks. One focused on access, one on assessment, one on treatment and one on discharge. Rob, what were the key stats?
Key stats, so we had a total of 84 people involved over the 4 weeks.
Yep.
We had an additional 48 feeding events. That's where people got the chance to either go to physical sessions to be able to talk about the particular topic that week. And we had around about 200 responses online to the survey questions using SurveyMonkey. So we had quite a good response.
So out of each week there was a whole wall's worth of flip chart that were developed and lots and lots of ideas put forward across the 4 weeks that were culminated in about 50 plus sort of features that were actually taken from the weeks. And what we've done with those is we've then tried to look at how they relate together. Each one has got a different level of detail and a different amount of work needed to create some detail around it. But now we've clunked them together into about 11 different work streams, which we want to take you through now, and then talk a bit about the next steps. So the first of those worth talking about would be access point.
Yeah, so the access point was very much about trying to have more direct access for local people and also for local stakeholders as well, to be able to get in contact with services. The potential about having some sort of advice line as well, so people could dial in and get support more readily. Was a key feature, and that would be manned and supported by a mixture of administrators and clinical staff, so as the expertise to support people when they called in.
Yeah, and because now obviously people have to refer to get into services largely, so to actually be able to ring up themselves, self-refer themselves, potentially maybe to service or maybe to go somewhere else, is like quite significantly different to what we've got at the moment. And then we really talked about, as part of the stream out of access, if you are in need of some support in an emergency, some crisis, about how that crisis worked. And then we talked about this didn't need to be a different crisis service, or at least the assessment part of that service didn't need to be different depending on age, which it currently is. And so what they really described was some sort of all-age crisis support or response, which means that if you're presenting, whether in the emergency department or whether in the community, and you're in need of crisis or you're in crisis support, that you'll be assessed by somebody who's got the skills to be able to see you irrespective of your age or whether you've got a learning disability, which will be quite different again. Once you go on to then some sort of home treatment, if you needed it, that would then be more specialised to meet your particular needs.
And I think that, the next feature, thinking about assessment, it was very much about getting people to the right place as quickly as possible to kind of prevent that bouncing around. So that assessment process, where it might be slightly longer for some services, actually the point was very much about getting people to the right place the first time. So getting the criteria really tight and making sure there's some sort of consistency, so that everyone's moving and flowing through the system at a similar speed.
And they described that, didn't they, in several stages as well. The assessment doesn't necessarily happen in one go.
Absolutely.
It's sort of like there's different parts to it, and how you get the kind of the talents of a multidisciplinary behind that, so that actually you don't have to go to one person and then bounce to another person to get another view. But there's a lot more to be still worked through, I think, in the detailed work.
Absolutely.
And then there's a big discussion around that treatment stuff. And the whole of pretty much the most dominant thing at the treatment workshop was about how do you organise that treatment into different pathways that brought together that best practice, and how was that structured? Was that structured around something we've got already, or was that something new? But these sort of intervention pathways, which are sort of treatment and support as it was described, needed to then increase the level of consistency that happened between where you live, where you present. So if you turned up in I don't know, Rutland, or you went into a service in the city, that you got broadly the same type of service irrespective, if you have the same sort of needs.
Yeah, and I think there was some flexibility in that as well, wasn't there? Because
Yeah.
someone might need a variety of interventions
Yeah.
and different pathways.
Yeah.
And I guess the standard was going to be someone could move based on their needs,
Yeah.
and that support would be brought around them,
Yeah.
rather than them having to be bounced back out of the system
Yes.
to then go into another
Yeah.
referral route, which just made things last far too long.
Yeah, so that multidisciplinary around the team, around the person themselves, rather than them having to move from one profession to another profession, etc., and all that bouncing potentially that might come out of that. And obviously the focus, which we'll come back to a little bit, about it all being not just about them, but also their family potentially, and the other people significant in their lives, and really seeing them in the round rather than just as a condition, or just that individual need. And then obviously there was about inpatient-community as well, and so there's quite a lot of discussion about how inpatient service and community got quite removed from each other, and how therefore the story, the experience, the knowledge around somebody when they've been seen in a community team, then moving to an inpatient, they get a completely different team, and that information doesn't seem to follow them necessarily, or sometimes it doesn't, not very clear. But there's lots to work on to bring that together, so the knowledge around somebody follows through, and the sort of stuff that, the treatment or the support they're getting there's some continuity that comes into that inpatient setting and then back out again, which means that it's just part of their journey rather than a completely different, separate journey and back again.
Yeah, I think people wanted a bit more clarity, didn't they, on sort of who takes that lead role when people are sort of changing from being in the community to inpatients going out again, and to, as you said, remain sort of consistent in that contact with somebody throughout that process.
Which I think then, part of that was described in a role, wasn't there? So there was this sort of like a lead professional that had that continuity all the way through their journey, maybe transitioning at certain points to maybe a different lead professional, but largely having continuity, because continuity is seen as a really important thing for people. And again, through inpatient out as well. And it wasn't described as brand new, there was the care program approach that was described as having something like that, but care program approach is not in place for everybody. And so to have this sort of level of continuity for everyone, irrespective of your complexity, was seen as like a value-added thing. Alongside them, because there's lots of coordination work, wasn't there, with all sorts of different potential voluntary sector organisations or social care or even health professionals around somebody. That burden of work, if you like, is put onto clinical staff, even if it might be just ringing people up and coordinating through one person or another. And they were seen as this other role, which was sort of around care navigator, I think was largely described, and the terminology seemed to be a bit Marmite. Some people liked, some people didn't. But the role itself was largely about how you coordinate people's care, about how you actually support the clinical team and the patient to be able to optimise that kind of coordination and sort of take it away from the clinical front line, free them up to do treatment and their skill work.
Absolutely, which brings us kind of nicely onto kind of like discharge process, and just how complicated discharge can be for people. Think about how there are lots of people involved in that process, and that care navigator being a really important part of being able to link and liaise and connect with people to bring that together so that discharge can happen at the earliest point when that person's
and that structure around discharge was sort of really emphasised, wasn't it? The sort of need to be thinking about actually having more planned times to review whether someone's really is the right place for them, to be linking, which we'll come back to, really the recovery journey, which was talked a bit about what that means, I guess. But building on the sense that these intervention pathways need to be a bit more structured around when people should be sort of heading out our services. They might not be better. I think that was the emphasis. It wasn't about you only discharge when you're well, because for some people that's not a reality that they like to be in. But their ability to cope, their ability to have a fulfilling life, I suppose, in this sort of community that's very individualised to their particular journey, which I think is then emphasised in that.
I think so as well,
approach.
Just the vast caseloads that we have at the moment, and the sheer number of people that are on some of our caseloads, and the opportunity to review some of those people, and the potential to be able to find support in other programmes, other streams and other places back in community might be something that comes out of this.
And so that wider collaboration was really talked about, wasn't it? And so it was, how do we collaborate with voluntary sector? voluntary sector being not just one thing. It's like a whole multitude of different organisations, different community groups, etc. But if we're going to have clinicians being able to helpfully signpost people into the voluntary sector, they've got to know what these voluntary sector organisations are, and they've got to have a relationship with them. There's got to be some sort of trust. And so we talked a bit about, or they talked a bit about how we kind of database actually voluntary sector. So there's a bit of order to it, a bit of organisation that people can self-navigate, but also clinicians can help them with. But also something about that, how you do build up that sort of trust around an organisation.
Yeah, and I think something about the VCS was recognised as strong and having sort of good local knowledge and various expertise. I think what the groups were saying was that a lot of relationships are based on people, and whereas what we need is more of a systemised approach, so that there's access and that anyone can access the services who can, rather than it being just through a person, but as you said, through a database or some updated information site that will be helpful to staff.
As well as potentially themselves to self-navigate.
Absolutely.
And they also talked about collaboration with social care. There's a general view that social care were very well integrated in the past, and then for various circumstances there's been a separation of social care and health, and broadly across both social care, individuals from social care that came and contributed to the design weeks, and from the health colleagues that did, the desire to see more integration. Maybe that isn't going back to the past, but it's a new future, isn't it, of how we do bring people together, whether that's co-location, whether that is a little bit of embedding within teams, whether that's something else. We don't really know. I don't think it was very clearly well described, but needing more integration was definitely higher on people's agenda, and then obviously primary care as well.
Absolutely, and I think the key challenge with primary care is the connection between secondary care staff and primary care staff, and how we can get them closer, working more closely together, particularly when there are certain agreements that need to be in place before people can then move on and out into general practice and support in their back home in their community. And there's a bit more work to do on that, though, isn't there, around really understanding the role of primary care.
I think that the conversations that have been taking place largely around how do you encourage a sense of, or not encourage, but create more free communication between GPs and secondary care professionals, so that people build the relationships. And if you've got the foundation stone of the relationships between GPs and their kind of their local practitioners, then suddenly everything becomes easier and people trust each other a bit more. There's still some questions to answer, like what expertise is needed to support people in primary care, which still needs to be explored, and there's roles in place at the moment which has got mixed views, so sort of building around them maybe, or perhaps reinventing it, but there's something about that as well, some intermediary thing between primary and secondary, or something to support primary care still needs to be thought through. So that'd be a part of that bit of work. I think all the way through the discussion there were a number of threads, weren't there, and primary care and collaboration was one of them, but also there's sort of how you use people who've got lived experience of mental health, and how they might be able to support people going through a service, sort of peer support worker type role. Yeah,
and I think people are really keen on that, actually being able to, I guess, use the expertise and the passion and all of the stuff that people know in terms of lived experience, and being able to bring that to people that we see, in order to have a different conversation that's perhaps more focused on what they can do, where they can get to, and provide that support on the ground, and just have a real contact, a real connection with the individual in a different way to a member of staff per se, that might bring about some positives for that individual.
Make it real for them, a bit more relatable than perhaps perhaps it's a bit stark sometimes, that professional and sort of patient the divide, if there is such a one. And then sort of transcending everything was this concept of recovery, and whether recovery is the right word or not, this concept of like I mentioned earlier, that people, that it's not necessarily about getting better. It's about being able to cope with your illness and having the understanding of what support networks around you, and being able to understand yourself, I suppose, better, and have it very contextual to your journey, so that we're not treating everyone by a condition necessarily. So that's the individualised bit. They are humans, they are individuals, they have their own journey, they have their own likely output out of this, and how we make sense of our system to be truly focused on recovery and empowering people and strengthening them, and us being just contributors to their own recovery plan, rather than it being in some ways our treatment plan that we're doing with them.
Yeah.
You know, it's a bit of a shift.
Yeah, and I think we learned just how much social factors play
Yeah.
on people
Yeah.
in terms of their health, and the importance of the family, where people
Yeah.
have families and close connections,
Yeah.
being able to have the right support around the individual
Yeah.
and around the family,
Yeah.
in order to keep them well and resilient, and to be able
Yeah.
to cope, as you said, but very much have that sort of, you know, that whole view of the individual,
Yeah.
in order to then hopefully
Yeah.
keep them and the families well.
And that lent on to the sense of carers in general.
Yeah.
And there was quite a lot of, I mean, we had people, carers coming to partake in the weeks, and they were big in contribution, and all along they were saying about how we've moved a bit away from how we might care for the carers, as it were, and their experience was that becomes something that local authorities are obliged to do in terms of their assessment, carers assessment, and organising things for them, and that we moved a little bit further away from it. But actually, if we pay attention to carers' needs, it benefits, you know, everyone. Because stronger carers will mean that people can be supported more themselves in their own family homes or whatever. And so we need to figure out how do we do that better, and having some sort of pathway that is oriented around carers.
Yeah, and one of the key points being that not everyone will recognise themselves as a carer.
Yeah.
There'll be a point, but it's having enough options available, part of the assessment, for example, to just pay attention to the individual who's, you know, responsible or taking some responsibility to be there, and support that individual, and giving them time to understand and learn and have knowledge so that they can do the best that they want to do in that situation.
So that brings us on to perhaps the last of our themes, which is infrastructure, and sort of enabling stuff. And there's a whole collection of other things. So where we do our work, so the estate, the kind of buildings that we work out of, that there's no real science between where they are at the moment. It doesn't necessarily match need, doesn't match transport routes, isn't necessarily accessible, isn't necessarily designed around people's needs. Don't really understand that yet. So there's some work done about really specifying what we would want from buildings, and actually trying to start to work towards having them
That's right. And we know that has a massive impact on patients and on staff as well. And we know that staff are working very hard at the moment in amongst high caseloads, and there's lots of challenges that they face. And also paying attention to them in terms of the support. And their development, and ensuring that, you know, the staff have got everything that they need to be able to do the best job and provide the care that they want to be able to deliver day in, day out, in amongst all of the mandatory requirements that, you know, that are expected of them.
Yes.
So it's a key area.
For Leicester Partnership Trust, I guess there was this reforming the relationship between the staff and them was quite a strong thing, you know, so that our staff felt more valued largely, and that came out quite strongly. And the sort of stuff that would make them feel valued, which was things like career progression, structure, but also about healing some of the things that have happened in the past. I think there's some emphasis around that. So there's more enough to work on, and obviously having the right IT systems was talked about all the way through the 4 weeks, and there is a movement at the moment, it seems like, to move on to System 1 for mental health services, but that needs to be done well, because it seems to be very important. It uses up a lot of time, and it could use up a lot of time unnecessarily if we get it wrong. If we get it right, then it will add. It will help people communicate, help people see things that they need to see, and have access to information. So there are the 11. Seems like a while ago since we started that, but there we go, we've got 11. So next steps. So we've organised that into the beginnings of a calendar. We want to design this. It won't all be done through workshops, because some are big and complicated and need lots of different bits of work around them. But majority of the work will be done in similar kind of co-design workshops, where we're trying to bring the right stakeholders together around each bit of work.
Yeah, and I think that's a key area. You know, we listened to some of the organisations and service users and carers, and I guess the format of the 4 weeks was potentially too much for some people to be involved. So I think we've heard that, and I think we're trying to do this differently now, so that we've got shorter time scales, you know, in terms of long days or long weeks, and we're trying to bring people in that it's, I guess, an amount of time that's, you know, that's doable for people, so that they can get involved. That's important.
So we'll find our way, I think, of that. We don't know if it's going to work, but so we're starting off. So as of, well, you'll probably see some dates. We've got a kind of series of events around interventions, that intervention pathway that we mentioned earlier, and that kicks off, in fact, on the 18th with some feeding sessions, and then followed with a workshop on the 21st, and then there's a following workshop in a couple of weeks after that. We've got a 2-day workshop looking at recovery. July we'll have a few days focused on crisis services and that all-age crisis, particularly the assessment bit of that. And then over the summer there'll be some continual work on the intervention pathways, and then some of the big workshops around the other areas will kick in September. But everything will be advertised on our website and through the kind of channels that we've been communicating already. So hopefully everyone will be able to see it if they're interested.